It shows few chest deformities. When we inspect the patient's chest, we have to note deviation in size and shape. In normal adult chest, the ratio of antero-posterior to transverse diameter is 1:2. And in normal adult chest, again, no structural deformities or visible retractions are there. The second uh, figure is of barrel chest. So in barrel chest, the antero posterior diameter is increased. The third figure is of scoliosis. So both kyphosis and scoliosis are spine deformities. Here we can see raised shoulders and scapula. The thoracic convexity is there and flared interspaces are seen. Um, and scoliosis is side to side deformity, kyphosis is antero-posterior deformity. Then the next slide is of pectus carinatum. It is also known as pigeon chest. So here there is anteriorly displaced sternum. The next figure is of pectus excavatum. It is also known as funnel chest. Here there is depressed lower end of the sternum. It covers some important clinical aspects related to the esophagus. So the first figure is of esophageal varices. Lower end of the esophagus is the site of portocaval anastomosis, and here the tributaries of left gastric vein anastomose with the tributaries of azygous or hemiazygous vein. And in case of portal hypertension, mainly due to liver cirrhosis, there is increase in the shunting of blood from portal to caval system through this collateral channel, and thus it causes dilatation and tortuosity in the collateral vessels present in the esophagus, and it is known as esophageal varices. And when they rupture, they cause hematemesis, which may be fatal. Now the second figure is of achalasia cardia. It is neuromuscular incoordination in which the sphincter at the lower end of the esophagus fails to relax when the food bolus is swallowed. Consequently, the food bolus will accumulate in the esophagus and it causes regurgitation. And it is thus a motility disorder. Now the third slide, it is of tracheoesophageal fistula. It is developmental anomaly. So first figure is normal. You can see esophagus and stomach lying anteriorly and posterior. It is there is esophagus and stomach lying posteriorly, and anteriorly we have trachea with two principal bronchus. So this is normal slide. Now in the second figure of this slide, we can see the proximal end of the esophagus is having atresia, and its distal end communicates with the trachea. It forms fistula in the trachea. In the second slide, there is fistula or opening of proximal as well as distal end of the esophagus into the trachea. And in the next figure, there is atresia of distal segment and opening of esophagus into trachea, that is tracheoesophageal fistula in the proximal part. In the next figure, there is atresia of both proximal and distal end, so both are not communicating with each other. Also, they are not communicating with trachea. And in the last figure, there is opening of esophagus in the trachea. So normally anteriorly we have the trachea with its two bronchus, and posteriorly there should lie esophagus and stomach, and there is no communication between trachea and esophagus normally, but this is a developmental anomaly. Now the next slide is of sliding hernia. It is herniation of abdominal viscera through the esophageal opening in the diaphragm. So at the level of 10 thoracic vertebrae, we have esophageal opening in the diaphragm. So when the abdominal viscera protrude out through this, either due to weak musculature around the esophageal opening, or weak phrenicoesophageal ligament, it leads to sliding hernia. So the gastroesophageal junction is displaced in the chest due to increased intra-abdominal pressure, and this hernia may cause abnormal gastroesophageal reflux. So there is pain, discomfort, which is referred to the pericardium and epigastrium. So this is the figure of sliding hernia, which is an acquired type of hernia, and it is diagnosed by barium meal examination. This slide covers important clinical aspects related to the thoracic duct. So the first figure is of chylothorax. Uh, It occurs when the chyle leaks into the pleural cavity. So the fluid present in the thoracic duct is known as chyle, and it is milky white secretion rich in cholesterol or fats. And when it when there is leakage and accumulation of this chyle into the pleural cavity, it is known as chylothorax. Cause is either traumatic or non-traumatic. Traumatic can be again iatrogenic due to surgery or radiation, and non-iatrogenic causes are blunt trauma or penetration to the chest wall. And non-traumatic causes are malignancies or severe infection like tuberculosis or superior vena cava obstruction. So to diagnose this condition, a chest radiograph is advised, and in that we can see pleural effusion, and when we investigate it, it is rich in cholesterol and triglycerides. So it helps in diagnosing the condition. Now the second figure is of Virchow's node. Virchow's node is a large lymph node in the left supraclavicular area. It drains the lymph from gut, and when it is enlarged, it is known as positive Troisier sign. It is also known as signal lymph node, and it can be one of the earliest sign of intra-abdominal malignancy, usually gastric carcinoma. So there is migration of tumor emboli through thoracic duct, and this supraclavicular or Virchow's node is located in venous angle at the junction of left subclavian vein and thoracic duct. Now the third figure, lower figure, is of thoracic duct fistula. So this commonly occurs when surgery takes place in lower part of left side of the neck, and it can lead to prolonged hospital stay, and the patient presents with leakage of milky white fluid from the neck following incision. And if this occurs intraoperatively, it should be repaired, but surgical guidelines for postoperative management are not clear. Slide is of sternal marrow biopsy. So if we see in infants, almost all the bones have red bone marrow, but as we grow, the red bone marrow is replaced by yellow bone marrow. Hence, in adults, the red bone marrow is seen only in cancellous bone and flat bones like sternum, skull, then ribs, iliac crest, hip bone, vertebrae, proximal end of femur, tibia, and humerus. So, when the study of bone marrow provides valuable information for evaluating some hematological diseases, we do marrow biopsy. And the sternum is preferred site of marrow biopsy in case of adults. The bone marrow is aspirated, and this is preferred site because the sternum is subcutaneous, easily accessible. So here the needle is inserted in the anterior aspect of manubrium. And sternal puncture, again we should note that the sternal puncture is not advised in children as it may cause mediastinal injury. We know that posterior to the manubrium in lower half there is arch of aorta, and in upper half it is related to left brachiocephalic vein artery and the left common carotid artery, left subclavian artery. So these may get injured in case of children as the manubrium is not well developed. So the bone marrow aspiration is done in children mostly along the upper end of the tibia or iliac crest. Slide is of thoracic inlet syndrome. So the thoracic inlet is formed by posteriorly first thoracic vertebrae. From posterior to anterior, the curve of first rib is there, and anteriorly we have costal cartilage of the first rib and superior border of manubrium sterni. So these are the boundaries of thoracic inlet, and there are two important structures that arch over the first rib. They are subclavian artery and first thoracic nerve. These structures may be compressed by cervical rib or by variation in the insertion of scalenus anterior muscle. So now we'll see what is this cervical rib. Normally, the ribs are present only in the thoracic region and they are not present in cervical region, and the ribs develop from costal element of transverse process of the vertebrae. And if we see the cervical vertebrae, there is foramina transverse area in the transverse process. Its dorsal part has uh, transverse element, and the ventrolateral part of the transverse process, which is lying ventrolateral to the foramina transverse area, it is known as costal element. So we do not have normally cervical costal element, but in case of cervical rib, the seventh cervical vertebrae has costal element, and from this develops the cervical rib. So we can say cervical rib is derived from the costal element of seventh cervical vertebrae, and it is present only in 0.5% of population, and it is often unilateral and more frequently found on the right side. And this rib will compress the brachial plexus, mainly the lower trunk, and subclavian vessels that are lying superior to the first rib, and it causes neurovascular uh, compression, which is known as thoracic inlet syndrome. Slide is of intercostal nerve block. Intercostal nerve block is indicated for repair of lacerations of thoracic and abdominal wall, or for relief of pain in rib fracture, or to allow pain-free respiratory movement, or in herpes zoster infection, which is very painful. Here the procedure is to produce analgesia of anterior and lateral thoracic and abdominal wall. The intercostal nerve should be blocked before it gives lateral cutaneous branch at the mid-axillary line. So the needle is injected, or it is inserted, and the direction is towards the rib near its lower border, and the tip of the needle comes to the subcostal groove where the local anesthesia is infiltrated around the nerve. So again here we have to remember that the order of structures lying in the subclavian groove are from above downwards. First there is intercostal vein, then intercostal artery, and then intercostal nerve. This neurovascular bundle is situated between internal intercostal muscle and intercostalis intimi muscle. The complications that can occur in this procedure are pneumothorax and hemorrhage. Pneumothorax can occur if the needle point misses the subcostal groove and penetrates too deeply through the parietal peritoneum. And hemorrhage is caused by puncture of intercostal blood vessels. This slide is of tube thoracostomy. A chest tube is inserted here, and the preferred site of insertion of tube thoracostomy is fourth or fifth intercostal space at anterior axillary line. Here the chest tube thoracostomy involves placing hollow plastic tube in pleural space to drain fluid or air from and around the lungs, and the tube is often hooked up with a suction machine to help the drainage, and a large volume of fluid can be drained, but we have to take precaution that we are not damaging the diaphragm or not entering into the peritoneal cavity. Slide is of flail chest. So it is a condition where severe crush injury occurs and number of ribs are broken, and if limited to one side, the fracture may occur near the rib angle posteriorly and anteriorly near the costochondral junction, and this causes flail chest in which a section of chest wall is disconnected from rest of the thoracic wall. And if the fractures occur on either side of the sternum may also flail, and in either case the stability of chest wall is lost and the flail segment is sucked in during inspiration and it is driven out during expiration, so it produces paradoxical and ineffective respiratory movement. When a foreign body is inhaled, it may pass into the lower respiratory tract, especially in children, and because the right bronchus is wider and more in alignment with the trachea, or more in direct continuation of trachea, the foreign bodies tend to enter into the right side instead of left bronchus, and from there they usually pass into the middle or lower lobe of bronchi. Significance of bronchopulmonary segments are the tuberculosis is more common in apical and posterior segment of upper lobe because of high ventilation perfusion ratio with elevated alveolar oxygen relative to other zones. Then sequestration of lung is more common in posterior basal segment of lower lobe. Again, it is more common on the left side compared to right. The cancerous lesions are more common in anterior segments of right upper lobe, and lung abscess is common in posterior segment of upper lobe or superior or posterior basal segment of lower lobe, especially on right lung, because of the vertical bronchus, and also that aspiration secretions tend to gravitate in these segments in supine position. Slide is of paralysis of diaphragm. Diaphragm is supplied by phrenic nerve, and phrenic nerve may be injured by penetrating wound of the neck or damage because of pressure from malignant tumors in the mediastinum. If the phrenic nerve is damaged, the corresponding half of the diaphragm will be paralyzed, and the paralyzed diaphragm will be relaxed and it will be pushed up into the thorax by positive or raised intra abdominal pressure. As a result, the lower lobe of the lung will collapse on that side. Previously, it was used as a treatment also. Surgical crushing of the phrenic nerve was done to produce paralysis of diaphragm on one side to treat lung infection like lung tuberculosis, and here the physician wishes to give rest to the lower lobe of the lung because the immobile dome of the diaphragm provides rest to the diseased lung. Again, here we have to remember that uh, accessory phrenic nerve may also be present. So the nerve to subclavius from its C5 root value, fifth cervical root of the brachial plexus, gives accessory phrenic nerve, and it leaves the nerve to subclavius and it joins main phrenic nerve in the thorax. It is of diaphragmatic hernia. So as we know, the diaphragm develops from septum transversum, which forms the muscles and central tendon. Then the pleuroperitoneal membranes form peripheral areas of diaphragmatic pleura and peritoneum, and the dorsal mesentery of esophagus forms the crura of the diaphragm. And if we see the diaphragmatic hernias, they can be congenital or acquired. So, congenital hernias occur as a result of incomplete fusion of septum transversum, dorsal mesentery, and pleuroperitoneal membrane from the body wall. The hernia occurs either at pleuroperitoneal canal, which is more common on the left side, caused by failure of fusion of septum transversum with pleuroperitoneal membrane, and it may also occur at the opening between xiphoid and costal origin of diaphragm or esophageal hiatus. Now, there can also be acquired hernia, which occurs mostly in middle-aged people with weak musculature around the esophageal opening in the diaphragm. So, acquired hernia, its types are either sliding or paraesophageal. Auscultation of lung is an important part of respiratory examination. It helps in diagnosis of various respiratory disorders, and auscultation assess airflow through tracheobronchial tree. It is important to distinguish normal respiratory sound from abnormal ones such as wheezing, pleural rub, rhonchi. So it helps in making correct diagnosis. It is necessary to understand the underlying pathophysiology of various lung sounds generated for better understanding of disease process. Are covered by serous mesothelium known as pleura. Pleura has two layers. Outer is parietal and inner is visceral layer. And in between these two layers of the pleura is the pleural cavity. Normally, maximum up to 10 ml of serous fluid is there in the pleural cavity. But when there is a collection of excess serous fluid in the pleural cavity, it is known as pleural effusion. Causes are either excess fluid production or decreased lymphatic absorption. And etiology is um, most commonly infection like tuberculosis, or there can be malignancy or congestive heart diseases. They can cause pleural effusion, and it is diagnosed by taking chest x-ray. So here in this figure we can see a PA view of PA view plain radiograph of chest. So here again for diagnosis we have to concentrate on the costophrenic and um cardiophrenic angles which are seen inferiorly normally, and in case of pleural effusion there will be obliteration of these angles because of accumulation of fluid. So here we can see the pleural effusion is obliterating the costophrenic as well as cardiophrenic angle. This slide is of bronchogram. Here we can examine the interior passage of lower respiratory tract. The structures of lower respiratory tract, which includes larynx, trachea, then bronchi, and these are all made visible by either inflating air or injecting contrast dye. Contrast dye is instilled through catheter or bronchoscope, and um, here we can see the contrast dye forms a coating on the lining of interior walls of the structure, and thus the outlining of the anatomy on these imaging techniques can help us in diagnosing abnormalities such as tumors, cavities, or cyst, or if there is any obstruction, it can be revealed by bronchogram. Bronchoscopy, a thin fiber optic tube known as bronchoscope, is passed through nose or mouth down to your throat and then into the lungs. and it is commonly performed using a flexible bronchoscope. And the indications for bronchoscopy are diagnosis of lung diseases, identification of lung infection, for biopsy of lung tissue, removal of mucus or foreign body or other obstruction in airway or lungs such as tumor, then placement of small tube to hold open an airway, means to place a stent, and it is also used for therapeutic purpose. Treatment of lung disease uh, is done. It is known as interventional bronchoscopy. So treatment for bleeding, abnormal narrowing of the airway like stricture or collapsed lung as seen in pneumothorax. So these are the indications of bronchoscopy. This slide is of postural drainage. So, excessive accumulation of bronchial secretions in a lobe or segment of lung can seriously interfere with the normal flow of air into the alveoli. Further stagnation of such secretions is followed by infections. So, postural drainage is often done at the time of percussion, and sometimes clapping is done, which involves someone clapping on your back, chest, or side with cupped hands in order to shake the mucus and loosen it from the lungs. This technique causes vibrations, and when it is used along with the deep breathing or huffling and coughing, it is referred as chest physiotherapy or airway clearance therapy. So the sound knowledge of bronchial tree is necessary to determine optimum position of patient for good postural drainage. It will give a way to use gravity to drain mucus out of your lungs by changing position, and it is used to treat variety of conditions such as cystic fibrosis, bronchiectasis, pneumonia. In the COVID era, we have seen the postural drainage is done. The patients are mostly asked to sleep in prone position. So the goal here is to move the mucus into the central airway where it can be cuffed up. It's safe for all people of all the ages, and it can be done either at home or hospital or nursing facilities there. So this is about postural drainage. Slide is of thoracocentesis. So the thoracocentesis is commonly indicated for diagnostic and therapeutic purpose. So, diagnostic is indicated for almost all the patients who have pleural fluid with uncertain etiology, and if more than 10 millimeter thickness of the fluid is present on computed tomography or ultrasonography or lateral decubitus x-rays, then we can diagnose pleural effusion, and it is not needed with there is known etiology like typical heart failure or viral pleurisy is there. Then therapeutic thoracocentesis is done to relieve symptoms in patient with dyspnea caused by large amount of this pleural effusion. There is no absolute contraindication for thoracocentesis, but relative contraindication is if the patient is having blood disorder or minimal fluid volume, or if there is cellulitis or herpes zoster or pulmonary diseases. And common complications are after doing this procedure, there can be pneumothorax or bleeding or hemoptysis due to lung puncture or re-expansion, pulmonary edema, hypotension, hemothorax. Occasionally, there can be puncture of spleen or liver, or vasovagal syncope can be there. Here, commonly used equipments are local anesthesia, lidocaine, then antiseptic solutions, then thoracocentesis needle and plastic catheters are used. Again, there are some considerations for thoracocentesis. Thoracocentesis can be safely done at patient's bedside or in outpatient setting, and ample of local anesthesia is needed. And thoracocentesis needle should not be inserted through infected skin like cellulitis or herpes zoster. Then positive pressure ventilation can increase the risk of complication. If the patient is receiving anticoagulants like warfarin, then we should give fresh frozen plasma. Now, positioning for thoracocentesis, it is best done with the patient sitting upright and leaning slightly forward with arms supported. So, recumbent or supine thoracocentesis in a ventilated patient is possible, but best done under ultrasonography or CT guidance. Here, the anatomical relevant points are: the intercostal neurovascular bundle is located along the lower edge of each rib. Therefore, the needle must be placed over the upper edge of the rib to avoid damage to the neurovascular bundle. And the liver or spleen rises during exhalation, and it can go as high as fifth intercostal space on right side or ninth intercostal space um, on the left side. And here again, if we go stepwise, first we have to confirm the extent of pleural effusion by chest percussion and imaging techniques. Then we have to reduce the risk of pneumothorax. To increase the success of the procedure, ultrasonography should be done, and select a needle insertion point in mid scapular line at upper border of the rib in one intercostal space below the top of effusion. Then mark the insertion point and prepare the area with the skin cleansing agent like chlorhexidine is used. And after that, the needle is placed. Um, Place local anesthesia over the insertion point first, and then the needle is inserted until reaching the parietal pleura, and it should be infiltrated with uh, the most as it is very sensitive, and continue advancing the needle until the pleural fluid is aspirated, and note the depth of the needle at which it is occurring. And then attach a large bore or needle catheter device can be used to drain, means tubing can be used here. Side is of barium swallow. So in barium swallow, the patient is asked to swallow a contrast media called barium sulfate, and then the radiograph is taken, and by using digital fluoroscopy, the radiograph is taken. So it is used to diagnose pathologies of throat, pharynx, esophagus, means the pathologies related to the upper gastrointestinal tract. So, in case of persons with stroke or disabling uh, speech muscles of the pharynx, here the speech therapist uses barium paste, and the person or the patient swallows it, and it is recorded on video tape. So, this is called barium swallow for pharynx. It is done in stroke patients to check the speech muscles. Then the second is for examination of esophagus. So there are two procedures again, one for throat and other is for esophagus. So the patient is lying in upright position, and it is examination is done under fluoroscopy. So, the filming is typically done using spot film camera or digital fluoroscope. For esophagus, we can use single or double contrast. So, barium should flow sufficiently to coat the esophagus, and the patient lies upright or recumbent position. And here again, we started with fluoroscopy, and the contrast media used is barium sulfate, and it can be thick or thin barium sulfate. So it is commonly used to see the patency of airway, like if there is any mass, foreign body, enlarged adenoids, or to check the epiglottis. And also it is used to diagnose the pathologies related to the esophagus, like tracheoesophageal fistula, foreign body, diverticula, esophageal cancers, then presbyesophagus, esophageal varices, esophageal benign strictures, and achalasia. So, if we see the appearance of each, now in case of tracheoesophageal fistula, it can be congenital or ulcerative. So, a fistula tract between the esophagus and trachea is visualized here. And the barium in the bronchial tree may result from tracheoesophageal fistula or aspiration of the barium. In case of foreign body, here radiolucent shadows are produced. Then we can check for the diverticula. It can be Zenker's diverticula, or it can be in middle or epinephric position. Then esophageal cancers. There will be narrowing of the lumen of esophagus with destruction of mucosa and irregular outlines with sharp edges, and dilated upper part of the esophagus is seen. The and again there is a condition called press by esophagus. uh, it is a press by means old, so it is used to describe dilatation and scalloping of the esophagus, which is generally seen in old age. Then the esophageal varices, for that we use Valsalva manure. We have patient first we ask the patient to deeply inspire, then swallow the contrast media, and be in recumbent position. So, in case of esophageal varices, we can visualize multiple submucosal feeling defects. In esophageal benign strictures, long strictures are seen with a smooth outline and dilatations. And a common cause of benign esophageal stricture is corrosive ingestion. Then, in case of achalasia cardia, that is a neurovascular disease, the dilated, smooth outline barium filled with esophagus with narrow tapering lower end of the esophagus with smooth muscle outline. And there is absence of fundal gas in the stomach. So it appears like rat tail or bird beak. So it is also known as rat tail or bird beak deformity, because the upper part is dilated and the lower part is tapering. So these all deformities can be seen by doing barium swallow. Internal thoracic artery is used in the treatment of coronary artery disease. In patients with occlusive coronary diseases caused by atherosclerosis, the diseased arterial segment can be bypassed by inserting a graft. The graft most commonly used is the great saphenous vein of the leg. In some patients, the myocardium can be revascularized by surgically mobilizing one of the internal thoracic artery and joining its distal end to a coronary artery. This slide is of myocardial infarction. It is commonly known as heart attack. It occurs when the blood flow through coronary artery stops supplying heart and causes damage to the heart muscles. And most common symptom is chest pain and discomfort. And it occurs when there is complete blockage of coronary artery caused by rupture of atherosclerotic plaque. It is usually the underlying mechanism of infarction. So there is gradual building of cholesterol and fibrous tissue in the plaque in the walls of coronary arteries, and it is known as atherosclerosis. So it is characterized by progressive inflammation of the walls of artery. The inflammatory cells, mainly macrophages, they move into the arterial walls along with low density lipids, and the smooth muscles try to stabilize the plaque, and there is calcification. So if the inflammation persists for longer time, then the cap becomes thin and it ulcerates, and it exposes the arterial wall to high pressure of a blood, and there is blood clot formation known as thrombus. Other causes of myocardial infarction are coronary artery spasm due to ingestion of some drugs like cocaine or sudden emotional stress. Then there are risk factors like high blood pressure, smoking, diabetes, lack of exercise, obesity, high cholesterol level, then excessive alcohol intake. So these are all risk factors. Diagnosis is done by electrocardiography or coronary angiography. Blood tests are there like troponin and creatine kinase MB. Okay. Then you can see the next figure. In that, cross section of anterior left ventricular wall is there, and you can see infarction in that. So if impaired blood flow to the heart lasts for longer time, it triggers a process known as ischemic cascade. So the heart cells in the territory of blocked coronary artery die due to necrosis, and it is known as infarction. There is formation of collagen scar in that place, and when the artery is blocked, the cells lack oxygen, and this leads to ischemic cascade, and then there is necrosis and apoptosis. Ischemia first affects subendocardial region of the heart. The tissues begin to die within 15 to 30 minutes of loss of blood supply, and the dead tissue is surrounded by a zone of potentially reversible ischemia that progresses and then becomes full thickness transmural infarct. And the position, size, extent of infarction depends on which artery is affected, or how much blockage is there, duration of blockage, presence of collateral circulation, and the interventional procedures that are done at the time of infarction or heart attack. And also, it is important to mention that collateral blood vessels are well developed in old age compared to young age. So, the prognosis of heart attack is bad in young person, or it is fatal because collateral blood vessels are not well established in them.
Is of cardiac tamponade. It is a condition in which blood or fluids fill the space between the pericardial sac that encloses heart, and uh, it exerts extreme pressure on the heart that prevents the ventricles from expanding fully. So the cardiac output is decreased, and the heart cannot pump enough blood to rest of the body, and thus it can lead to organ failure, shock, or even death. So it is an medical emergency, and it is usually a result of penetration of pericardium, which is a thin double walled sac that surrounds the heart, and the cavity around the heart is then filled with either blood or fluids that compresses the heart, and the fluid uh, that surrounds the heart will compress it, and uh, therefore less blood can enter into it, and less oxygen rich blood is pumped to rest of the body, and lack of blood uh, from the heart to rest of the body will lead to shock, organ failure, and cardiac arrest. Most common cause is penetrating wound or accidental perforation or puncture, or infections like tuberculosis, then malignancy, ruptured aortic aneurysm, or pericarditis, hypothyroidism, high level of radiations to the chest. So these are all common causes of cardiac tamponade, and the patient presents with anxiety, restlessness, low blood pressure is there, weakness and chest pain, trouble in breathing, there is rapid breathing, and discomfort is relieved by sitting or leaning forward. And clinically we can diagnose the cardiac tamponade by Beck's triad. There is low blood pressure, extended neck veins, and rapid heartbeat. And the diagnostic test used are thoracic CT scan or magnetic resonance angiogram, and electrocardiogram is used to assess the heartbeats. And it is treated by pericardiocentesis. So it is a medical emergency, and it is treated to relieve the pressure on the heart. So the doctor will drain the fluid from pericardial sac by using a needle, and this procedure is known as pericardiocentesis, or more invasive procedure known as thoracotomy is used in case of penetrating wounds. If there are blood clots, then the blood clots are removed. This slide is of atrial septum defect. Atrial septal defect is a congenital anomaly involving defective formation of interatrial septum, and therefore there is communication between right and left atrium. There are different types of atrial septal defect. First is ostium secundum defect. Failure of septum secundum to cover septum primum results in ostium secundum defect. It may be due to short septum secundum or more absorption of septum primum. So here a large foramen ovale is seen. Second defect is septum primum defect. There is failure of septum primum to close foramen primum. Third is endocardial cushion defect. So there is failure of fusion of septum primum with endocardial cushion or septum intermedium, and it results in persistent foramen primum. Then the fourth defect is sinus venosus ASD. Here, incomplete absorption of sinus venosus in right atrium results in a defect in the atrial septum. Then there is other variety which is very rare, that is uh, cortreo-ocular biventricular chamber. Means here the interatrial septum is completely absent and a single atrium is present and two ventricles are there. Then there is probe patency test for foramen oval. Normally just after birth foramen oval closes physiologically. And anatomical fusion also takes place, but in 20% cases anatomical fusion does not occur, and a small probe can pass through foramen oval. And, failure of fusion of septum primum with septum secundum results in patent foramen oval. Slide is of ventricular septal defect. It is most common congenital anomaly of heart, and it is more common in males than in females. In ventricular septal defect, membranous part of the interventricular septum is involved, and there is failure of fusion of right and left bulbar ridge with the atrioventricular cushion. So there is communication between right and left ventricle, and shunting of blood occurs from left ventricle to the right ventricle. Side is of tetralogy of Fallot. So tetralogy of Fallot is a congenital heart disease, and it has four components: pulmonary stenosis, right ventricular hypertrophy, um, then ventricular septal defect, and overriding of aorta. And the cause is, it is associated with maternal phenylketonuria, and diagnosis is done by echocardiography and x-ray chest. Boot shaped appearance of heart is there in Fallet's tetralogy, and here the pulmonary stenosis is the root cause. So due to pulmonary stenosis, concentric right ventricular hypertrophy occurs without cardiac enlargement, and there is increase in right ventricular pressure. Blood shunts from right ventricle to left ventricle through ventricular septal defect, and there is ejection of mixed blood to the aorta. So there is cyanosis and overriding of aorta is the disposition. Clinical manifestations are, we say, blue baby. They have cyanotic lips and nail beds, and fatigability is there. Then acute hypoxic spells are characterized by shortness of breath, cyanosis, agitation, and loss of consciousness. Slide is of patent ductus arteriosus. Failure of closure of ductus arteriosus that connects left pulmonary artery with arch of aorta in fetal life leads to patency in ductus arteriosus. Normally, it shunts blood from pulmonary trunk and to the descending aorta to bypass lung, and usual closure of ductus arteriosus occurs as physiological or functional immediately after birth due to reflex contraction of muscles of atrial wall, and ductus arteriosus constricts at birth, but shunting of blood from aorta to left pulmonary artery may continue up to 4 days after birth. And anatomical closure of ductus arteriosus occurs within 3 months or 12 weeks after birth by proliferation of tunica intima into the lumen under influence of transforming growth factor. And patent ductus arteriosus leads to shunting of blood from aorta to pulmonary circulation, and prostaglandin keeps the ductus arteriosus open, whereas prostaglandin inhibitors such as endomethacin promotes closure of the duct. And mechanism of closure is after birth lungs release bradykinin during initial inflation, and it produces smooth muscle contraction in the wall of ductus arteriosus, and it closes physiologically. Remnant of the duct is also called as ligamentum arteriosum, and the left recurrent laryngeal nerve loops around the ligamentum arteriosum. Is of transposition of great arteries. So the two arteries arising from the heart and carrying blood away from the heart are aorta and pulmonary trunk. In this condition, these two arteries are transposed from their normal position. That means aorta arises from right ventricle and pulmonary artery arises from left ventricle, and in 25% cases it is associated with ventricular septal defect, or the branching pattern of the coronary arteries also unusual, and the infants may show narrowing below the pulmonary wall. So this blocks the blood flow from left ventricle to the lungs. In transposition, uh, a situation arises where the systemic blood carried to the body and pulmonary blood carried to the lungs. So these two circulations are not working together. This means oxygen poor blood returning from the body courses through the right atrium to the right ventricle, and then from the aorta this blood will pass to the body. The oxygen rich blood returning from the lungs and through the left atrium, then to the left ventricle, is sent back to the lungs by the pulmonary arteries. So, here there is in some place in which the circulation where oxygen rich and oxygen poor blood mixes, and the organs of the body will not get oxygen required amount of the oxygen, and it may also be associated with atrial septal defect or patent ductus arteriosus, and it is diagnosed in fetus through fetal ultrasound, or fetal echocardiography is done, and after birth, within few hours or few days of life,
There will be cyanosis and low oxygen level. All the babies have patent ductus arteriosus at birth that may allow enough mixing to prevent severe cyanosis. As the ductus arteriosus closes, the cyanosis will become more severe. There is a murmur in the heart, congestive heart failure may occur, and for a treatment purpose, there is a procedure known as balloon atrial septostomy. It is done for this condition. This slide is of dextrocardia. Dextrocardia is a rare heart condition in which the heart points towards the right side of the chest instead of left side. It is congenital anomaly. In case of isolated dextrocardia, the heart is pointing towards the right side, but there is no other defect. In a condition known as situs inversus, many other visceras are on the mirror image side of our body. In addition to heart, liver, spleen, and other organs are located to the opposite side. Uh, Cause of dextrocardia is not known, but it is congenital, and it is often associated with septal defects in the heart. And the symptoms in dextrocardia are usually there are no symptoms, and the condition is found on X-ray or MRI of the chest. So it shows the heart pointing on the right side of the chest. And in case of isolated dextrocardia, there is increased risk of lung functions, sinus infections, or pneumonia, and the cilia may not be functioning in the lungs. So, um, again, dextrocardia affects the heart function, and if it is affecting the heart functions, then the symptoms are breathing difficulty, cyanosis, blue lips and skin, easy fatigability. Child with dextrocardia may not develop correctly or may need surgery to correct the defect. Lack of oxygen to the heart can make the person feel tired easily and keep them from growing normally. And abnormalities related to the liver, like jaundice, can be there. And often a baby with dextrocardia has septal defect, and we treat dextrocardia only if it is interrupting the vital functioning. Pacemakers and surgery to repair the septal defects can help the heart work normally. And if there is infection, then medications are given to reduce the risk of infections. It is of coarctation of aorta. So, coarctation of aorta is a condition in which the aortic lumen beyond the origin of the left subclavian artery is narrowed, and it leads to partial or complete obstruction of blood flow into the descending aorta. And the cause of aortic narrowing is primarily abnormality in tunica media of the aorta, followed by intima proliferation. There are two types of coarctation depending upon the site of constriction, whether it is proximal or distal to the ductus arteriosus. They are named as preductal and postductal. Preductal type is exaggeration of normal narrowing between left subclavian artery and ductus arteriosus, and the ductus arteriosus remains patent in this type, and it results from poor blood flow in this segment. And the second variety is postductal type. This is exaggeration of normal indentation of the posterior wall of aorta. Here, the ductus arteriosus is usually obliterated, and collateral circulation between proximal and distal part of the aorta is established by hypertrophied intercostal and internal thoracic arteries. And radiologically, the dilatation of engorged intercostal arteries produce notching of the lower border of the ribs.
Is of aortic aneurysm. Aneurysm means dilatation. So there is dilatation of aorta. It can occur in the thoracic aorta or in abdominal aorta. So the uh, thoracic aortic aneurysm occurs in chest, and it is equally common in male and females, and it is more common with increasing age, and it is usually caused by high blood pressure or sudden injury, and it is also inherited. Connective tissue disorders such as Marfan syndrome, Ehlers-Danlos syndrome. So in these conditions, thoracic aortic aneurysm is seen, and the signs and symptoms of the aneurysm are sharp sudden pain in chest and shortness of breath, or trouble in breathing or swallowing. Then the second type is abdominal aortic aneurysm. It occurs below chest in the abdomen, and it is more common in men over 65 years of age, and it is again caused by atherosclerosis, and infection or injury can also cause them. So there is throbbing or deep pain in the back or sides, and pain in the groin region or legs. And most common complication of the aortic aneurysm is rupture or dissection. A force of blood pumping can split the layers of the arterial wall, and it allows the blood to leak in between them. This procedure is known as dissection, and sudden burst of aneurysm completely uh, splitting all the layers of arterial wall causes bleeding inside the body. This is known as rupture. So dissections and ruptures are most common cause of death from aortic aneurysm. Side is of coronary angiogram. It is a procedure that uses imaging techniques to visualize the blood vessels of heart, and this test is generally done to see if there's a blockage or restriction in blood flow going to the heart. And coronary angiograms are a part of uh, a procedure known as cardiac catheterization. So cardiac catheterization is a procedure that can diagnose and treat heart and blood vessel conditions. So a coronary angiogram helps to diagnose heart conditions, and it is the most common type of cardiac catheterization procedure. During angiogram, a dye is injected that's visible by imaging techniques, and this dye is injected into the blood vessels, and then a series of images is taken known as angiogram, and it helps in visualizing the blood vessel, and if necessary the doctor can operate the clogged blood vessels, that is known as angioplasty. So angioplasty can be done during coronary angiogram itself, and indications for coronary angiogram are uh, unstable angina, increasing chest pain, or congenital heart diseases, or abnormal results on non invasive heart stress tests, or if there is any pathology of heart walls. So there are minor risk factors while doing this procedure. Some complications can occur like stroke, or ischemic heart disease, or injury to the catheterized artery, or arrhythmias. Sometimes allergic reactions occur to the dye or medication that is used during the procedure. So it has very few complication, and because of these risk factors it is not routinely done. First we do non-invasive heart test such as electrocardiogram or echocardiogram, and then there are some stress tests, and if there are abnormal results of these tests, then
coronary angiogram is advised.